presenter view, but are you seeing just the slides and not the presenter view there?
That looks perfect.
Okay, so let's go ahead and get moving. Again, this is me. I work at an FQHC. Opinions are my own, although our FQHC is strongly in support of this, and I hope that it can become the norm rather than the exception that a primary care clinic will treat these things, and that's why I'm part of why I'm so excited to be here. I don't have any industry ties or anything. My usual joke is if you can connect me with some like slush funds or whatever, hook me up after the meeting. Most of this is from the public domain and is expert guidelines. Some of it is original to me. Most of it's not. I'm not that smart. But I'll try to be very clear about where it comes from, source it so you can go to the original places and double check me. And this is the technical part. Let's see if this works. Vivek Murthy, previous and current and outgoing Surgeon General, talked a lot about turn the tide and was very vocal about the opioid epidemic, and then recently loneliness. And so I have another quick expert opinion here about whether you should treat people who are pregnant who have opioid use disorders. So let's see if this works here. Uh, Great. I don't care. Okay. Well, let's get away from this nonsense. So the quick video is the Street Fighter character Bison saying yes, and then that's it. And I was gonna be like, okay, I'm done. Will, back to you for questions. Okay. In seriousness, there's more to it than that. But should we treat people who are pregnant? Yes, 1,000,000%. Absolutely, we should. If you remember nothing else, take care of people who are pregnant. That's a time where, as we in primary care know very well, you have a unique connection to people. People's motivation can increase a lot because they care about the other human that's now in their lives and physically in them. And there are some special considerations, but that's absolutely not a time where we want to be judgy, abandon people, all that stuff. You all know this. So I'm going to talk about opioid use disorder treatment, a brief touch on pain because pain can go together with that. Opioids can come up in pregnancy. Pregnancy is associated with some painful things intrinsic to itself, and people who have chronic pain can and do get pregnant. And we also want to make sure we don't lead people who are pregnant or into an opioid use disorder or just preconception planning, as we know. I'm going to talk briefly again about some infectious diseases. I mainly want to focus on opioid use disorder and just think about stuff that you may do probably with a specialist as you're helping someone plan pregnancy when you get that chance, and also what to be thinking if someone comes in and surprise they're pregnant. And we're going back to embryology for those of us who went to UNMC. Flashback to Dr. Turpin talking about the different layers and getting out your different colored pens and highlighters for like red, green, and purple and stuff. But in weeks 6 through 8, we've got organ differentiation and organogenesis. So a lot of the time, by the time somebody realizes they're pregnant, this has already happened. Not necessarily, but the cat may be out of the bag, so to speak. Here's your flashbacks to your embryology lectures. Uh, and the takeaway is at the end of week 8 of pregnancy, your organ systems have developed and are maturing. And then week 9, which again is quite early, people may or may not have even realized they're pregnant by then. A lot of people will, but if you have irregular menses, you may not. Your organs are set. And so concerns about, are we going to have increased risk of fetal congenital malformations or anything? Most of the time, by the time we realize what's going on, whatever has happened has happened. And I'm going to touch briefly on is there an association between opioid use disorders or opioid treatment and fetal malformations? But the vast majority of the time, your focus is going to be okay, you're here, you're already this far along. What do I do to help you have a healthy pregnancy? Because healthy mom, healthy parent equals healthy baby. Uh, Somebody who we taper off or who we refuse to treat, that's like there's a high chance things are not going to go well. And the risks of that are pretty much always going to be a lot worse than the risks of treating somebody. So, So opioids do cross the placenta. There is some concern about, again, at the neurological level, as well as the hormonal level, and then we're going to talk a bit about NAS or neonatal abstinence syndrome too. There is some concern for opioid exposure of any kind, impacting long-term cognitive and behavioral offspring or behavioral outcomes in offspring, aka kids. And I've got that link there to the neuroimaging. But there's a lot that goes into that. And if we think about some of the people we take care of, or maybe if it's impacted a loved one of ours, what they were going through with this, the vast majority of people who need opioid use disorder treatment are not needing it because everything in their life is amazing. We know that adverse childhood experiences are very common, and people's current housing, economic, relationship situation, what kinds of trauma they have been through may be going through, what their mental health concerns are, all that stuff plays a role too. And shockingly, that also will impact how somebody does, with epigenetic expression and their health behaviors during pregnancy, how they're going to be able to parent and how much bandwidth they have to live their life the way they want to after birth and stuff. Is it, are opioids responsible for this? Well, probably, and other drugs and smoking and nutrition status and safety and security and education and socioeconomic status. And so it's like, is it that? Well, yes, how do you tease out, is it just opioids? You probably can't. I mean, maybe somebody smarter than me can design that study and power it appropriately. But in this context, again, should we tell somebody no opioid treatment for you if they need it? I would argue no, we shouldn't. And that's not just my opinion, as we'll see here with these guidelines in a second. But again, there's a lot that goes into it. And if patients or like family members, parents, spouses, other loved ones, or the patient themselves is like, should I do this? I mean, you can say, there's a lot to it. And again, what's the risk of opioid exposure versus what's the risk of telling you to just white knuckle it through 9 months of pregnancy and hope everything goes well when we know it probably won't. The odds are not in their favor. And then we have to think about what happens with if somebody withdraws. So hopefully that's not that they're being forced to withdraw. That can happen in the carceral system. Have worked with an OB-GYN who had somebody who was in a county jail who needed to be induced but didn't want to because the non-provider in charge of her medical care was saying, well, the Suboxone is only for the baby. So as soon as you deliver, no more medicine for you. And the mom was logically terrified of going through withdrawal, and so was not wanting to get induced, even though she obstetrically needed to, because of this punitive, poorly informed, and really quite ignorant idea by the county jail person who was overriding multiple medical providers and telling them what to do. But again, if you withdraw somebody forcibly, or if they are relapsing and then they go into withdrawal on their own, since before I was born, we have known that there are higher rates of stillbirths and meconium aspiration, which is not great. And Going back to when methadone was the approved treatment for this, prenatal care was better. Other illicit drug use was better. Fetal withdrawal was less. And again, withdrawal is bad for a fetus too. And so this forms the foundation of this professional society recommendation from ACOG and others. Do treat people. Do not forcibly withdraw them. Do not, kind of push them to go off themselves because that's bad for mom and baby too. I mentioned the ACOG guidelines. I'm going to reprint some of what they say here. There's also some information from SAMHSA, which is similar in its approach. And then this is straight from ACOG. All healthcare providers need to be part of this. Love that. That is true. That includes OB-GYNs, surgeons. That includes us who are primary care. That includes us who are psychiatry and mental health specialists. That includes other subspecialists, pediatricians, geriatricians. Like this is an all hands on deck kind of a thing. And again, pregnancy, as we know from continuity care, it's a unique opportunity to meet people and either to like help them and reassure them and be good to them, or maybe to be judgy when they are really in need and uniquely vulnerable and be bad to them. I don't think that's why anybody's here. And then substance use disorders don't discriminate, although there are discrepancies based on other social determinants of health in terms of who is more likely to use what substances, and then how much access to care and treatment they have. Shout out to all my rural colleagues and also anybody who may be working like with the Indian Health Service, because those things are real. And then those of us who are seeing immigrants and others in like urban settings as well as rural. Uh, the more minority identities you have, the more challenges you are going to have face or getting health care. But we also shouldn't typecast and say, like, well, you have these identities, so we're going to screen you. But, like my wife, who's, white and cisgender and well off and, highly educated and all that stuff, can't affect her. So we're not going to screen her. That would be wrong. Screen everybody. This not only is important because addiction doesn't discriminate, but also because it normalizes the discussion about that. This is something I see with other things like HIV screening and STI screening. If it's not like you look a little, we're going to screen you, but like, no, we really do screen everybody. It gives a chance to talk about things, and it just changes the conversation. And then if you've talked to maybe parents or a spouse, then when their loved one or their kids come in and we have that conversation, they're like, oh yeah, no, we talked about this too. Instead of like, what do you mean? Why are you asking that? So that's an important part of just the overall conversation here too. And again, this should be part of comprehensive OB care and should be done in partnership. I think that's a good thing too. Not punitive or like, aha, gotcha, but like, how do we work together? Because you're here in the office because you want a healthy pregnancy. Love that. We're here for you. Let's work together. So, and again, diversity, whatever certain figures in the media say, that is an important thing to be thinking about. And looking at prescribed opioid medical treatment, whether for pain or for substance use disorder or like maintenance of OUD. Um, Misuse where somebody is having risky use, but is not necessarily meeting the criteria for the use disorder, and then an untreated opioid use disorder, which we may know about because somebody may have that, and then we're trying to treat them and they're not there yet, and then surprise, they're pregnant. Or they may have had that going on, and not been in medical care, or been in medical care and not disclosed that, and now the pregnancy is the first time that they disclose it or it becomes obvious. So and then we should have medical treatments, developmental and therapy support for the kid as needed after birth, social support with social workers and other programs, which will vary community by community. And then infants need to be monitored for NAS or neonatal abstinence syndrome by a pediatric provider. Typically, this will be in a NICU here in urban settings like where I am. This may be your pediatricians in a rural setting. I do have a brief review of some of the guidelines there, but that'll be dependent on your local resources. For those of you who do obstetrics, talk to your local people. For those of you who are working with the obstetricians, whether family med or nurse midwives or OB-GYNs, talk to them. And you may be in the situation like me of negotiating medication for somebody who's pregnant and going to deliver. And like one of my patients had a C-section. So I was talking with their MFM and their OB-GYN about what's the medicine going to look like, who's going to own responsibility for that. I'm asking them, please do this or don't do this with their buprenorphine treatment while you manage other things, and just communicate. So okay, so again, early universal screening is a good idea. And then obviously referring for treatment improves maternal and infant outcomes. So like that YouTube clip that didn't work for, I don't know why, that did when I practiced. Should we do this? Yes, yes. So, and then a coordinated multidisciplinary approach without criminal sanctions. This is not, like some bleeding heart leftist thing. This is ACOG. Again, less punitive, more collaborative is the standard to help the infant and the parent and the family do as well as possible. So, and again, early universal screening, and then just repeating, do this as part of comprehensive OB care, just like we're thinking about nutrition, we're thinking about safety, we're thinking about vaccines, we're thinking about management of other chronic conditions. It should just be part of the package deal. And then again, making it universal helps avoid that stereotyping and stigma, which again, I've seen that happen in my career based on race, based on other factors. That's not cool. That's not why any of us are here. I know. So just trying to do that because again, that does help in a broader way to make it universal than just that individual encounter too. So there are some screening things here, and I'll keep moving. But this is in my slides if anybody would like them, and you can look those up. It's also just again straight from the ACOG guidelines. Then, when chronic pain is present, which can and does happen, trying to avoid or minimize the use of opioids and not lean on them, because the more opioid exposure we have during the pregnancy, the more concern for neonatal abstinence syndrome. And if they do need a C-section or other operative intervention, or like, intraparta or like a chole during their pregnancy or something, which is rare but happens, as with any surgery, the more opioids you're loaded up on going in, the more your receptors are saturated, the more challenging intra-op and post-op pain management can be. And just telling people that to partner with them, like we said. And then trying to use non-pharmacologic and non-opioid treatments to the maximum extent possible. I think we're all already there in terms of our view on that. And then again, just the big thing, if you remember nothing else from my highly caffeinated presentation here, uh, please do give people meds or advocate for them to get meds, uh, which can include like talking to other medical providers, talking to surgeons, talking to people at jails who don't know what they're talking about and think that they know what's best, even though they are not having a medical degree. Just always, always, always advocate for people to have access to pharmacotherapy rather than being forced to withdraw. Making people withdraw when they're not pregnant, and especially when they are pregnant, is associated with high relapse rates, worse outcomes, uh, unintended overdose and death, all the other bloodstream and infectious complications that can come from unsupervised injection drug use, risky behaviors, risky sex, all those things, housing instability, maybe even being trafficked, all that bad stuff. Like that's bad. Nobody likes that. And in pregnancy, all that same stuff applies, except now you may be harming the fetus or baby too. Again, just always advocate for people to have access to maintenance treatment. And then I think this guy's name here is Phil. That was just what I found when I was Googling stuff. So that's the extent of my technical abilities. Okay. And then again, we should have PEDS or NICU monitoring. I don't think anybody's going to be too hard to convince about that. And then again, being mindful that if someone has an opioid use disorder, that may have driven them or maybe currently driving them to riskier behaviors. Continue to offer STI testing, and then continue to monitor fetal weight, looking for things like IUGR, intrauterine growth restriction, if there's also smoking or other stimulant use going on. And then consult the people you need to consult, get on the phone with your specialist colleagues, know your local network, and then at the state level, talking to the experts in this group, talking to your MFM provider, maybe, from across the state here at Nebraska Medicine, or maybe over in like Denver or Rapid City, depending on where you are. Just get some friends in the boat with you and focus on how do I help this patient, both these patients, do as well as possible. And then again, if opioids are considered, talk a lot about that. I believe later in my slide set here, short-term opioid use is not associated with worse fetal outcomes for like a broken bone or, like a quick gallbladder thing or something if things are severe, particularly in the third trimester when we should avoid NSAIDs. This is more like long-term and just educate people and if they don't already use opioids, if we're not talking about opioid use disorder maintenance, try not to lead people into that if at all possible, of course. And then use the PDMP, all the usual things that we already know to do anyway. So, and then we should encourage breastfeeding, particularly that leads to less neonatal abstinence syndrome. And outside of things like HIV, which here in resource-rich settings, breastfeeding is usually not recommended. We should highlight that has advantages. Lactation consultants as needed, support parents through this, but that if they can, that has demonstrated benefits. And then support services, which again will vary based on your local setting. Try to know your local resources. Give people access to ongoing treatment, which if you're the obstetrician, you may be handing them off. If you're the primary and or the addiction specialist, that's probably going to continue to be you, and you'll keep working with the pediatrician and the delivering provider and their continuity provider if that's not you. And then contraceptive counseling and access to services should also be offered. We should offer that to everybody, and particularly if somebody's been in a housing unstable or like a traffic situation. Hopefully not, but we know that that's a thing. Offering them options to control their own reproductive freedom is something that ACOG recommends. But again, everybody should have access to that based on their own unique values and preferences. So, buprenorphine versus methadone is for most of us, this is a moot point because methadone is still only available in opioid treatment programs because of a Nixon era legal regulation, if I remember correctly. Not anything to do with the medicine itself. But should we choose one over the other, presuming we have both, which here in Omaha we do, and I could push a patient one way or the other. So this PICO intervention of like, is there head-to-head evidence of methadone versus bupe in terms of birth weight, preterm delivery, and neonatal abstinence syndrome? Why, yes, there is. So here's this New England Journal article, which I've linked to the original here. And from that, this had a pretty large study group, and then several thousand folks here with bupe and methadone. And they were looking at exposure early in pregnancy and or late in pregnancy, so pretty good data set. And there was less neonatal abstinence syndrome with bupe exposure in 30 days before delivery versus methadone. And there was also less preterm birth. And the C-section rates were about equivalent. And so their conclusion, using buprenorphine as the agent of choice, which again is what most of us can do in an office-based setting anyway, has lower risk of neonatal adverse outcomes than methadone use. But for moms, it was pretty similar. So this is kind of reassuring. If you're using buprenorphine in an office-based setting because you're rural or because the patient is not able or prefers to have office-based treatment with you instead of going daily to an opioid treatment program, don't feel like you're giving them worse care. In fact, there's a good argument you're giving them better care by doing that. That said, if somebody's been doing well in an opioid treatment program or is just does better on methadone or is doing well on methadone and has never been on buprenorphine-based treatment, I don't know if this is strong enough to say make them switch because switching in and of itself offers some risks, as we know. But again, if they're already on buprenorphine, feel great that you're giving them something that has better outcomes. Then I highlighted this because I'm a primary care person, so shocking. People who were on buprenorphine-based treatment were getting more screening. They had higher rates of anxiety and depression diagnoses. Does that mean they were more anxious and depressed, or does it mean that the primary care person was screening for that more, which we typically do and we should, than the opioid treatment program, which is more focused? Also, were they getting more like STI screenings, more other services because they're with a primary care person whose job is to do all those things? Uh, yes, that was what they thought. And I think that tracks with what we know that a very specialized, hyper-focused clinic is going to do their thing. Primary care does all the things, and that's another potential advantage of getting buprenorphine office-based treatment, that you're going to be getting that from a place that thinks about all these things. So now we're getting to 8 o'clock, but again, there was the more people were using bupe, like more bupe versus methadone, uh, better outcomes in terms of NAS, preterm birth, small gestational age, size, low birth weight. The only things where methadone was equal were C-sections and severe maternal complications. So I think this is a great argument to, yes, use buprenorphine. So okay, and then wrapping up with bupe, volume of distribution may change, and this is my personal eminence-based answer, and I ask people how they're doing, adjust their dose as needed. You may need to go higher than 24 milligrams, and you may need to divide that, especially if they have chronic pain, as opposed to doing once a day if it's more withdrawal prevention. Just keep talking to your patients, and then talk to the other specialists, the OB-GYN or FM surgeon if needed, and make sure there's good communication. So this study, which I've got the link up here, showed that there was not, having people on buprenorphine didn't lead to worse outcomes, and doses varied from 2 to 34 milligrams per day. Just get patients what they need, and advocate for them to be able to continue to have it would be my statement. So And then, Will, I don't know if you want to pop in. I want to make sure we have enough time for questions. I've got some more material here, but should I keep moving through that?
Yeah, folks, if you have any questions, you can feel free to start dropping those in the chat. I haven't seen any questions come in yet. So maybe if you want to keep going, we can pause again in 15 minutes or so and see if we got any questions.
Yeah, 15 minutes should be enough. So, okay.
Okay.
And if not, we'll make it enough. So, okay. So speaking of agitation and hyperstimulation, opioid withdrawal in neonates causes CNS excitability and irritability. So tremors, stiff or rigid muscle tone, vasomotor signs, GI signs, like the same stuff that happens in larger humans. Um, and this can go from earlier on versus later. And again, this is directly from this North Carolina document. So severity is going to be also impacted by is the parent using other substances too, tobacco and barbiturates like butalbital, or that's the main one we usually see these days. And then here in North Carolina, anyway, they were saying that polysubstance use is more the exception than the rule, except if someone comes to you, like some of my patients have, in recovery on buprenorphine-based treatment, doing well. They get pregnant, yay, everybody's happy. And then also, if people are using prescription opioids and did not have a diagnosed opioid use disorder, and then they become pregnant, yay, everybody's happy. That there's polysubstance use is less likely there. But I'm thinking of one of my patients where I managed her opioids through her two pregnancies now. She had first she had a big fat happy baby, and then she got pregnant, and now she has a fat happy baby and a fat happy toddler, and everybody's doing good. And she took buprenorphine throughout. We did razor dose during the pregnancies, and then back off afterward, and she's done very nicely. So, but if somebody comes in, like some of my other patients who I've seen who have HIV or other things going on, and they're not in recovery yet, then you should be expecting that other things will be there. That also influences NAS. So, and then, yeah, this is more NICU, but or PEDS, but again, you're going to be looking at doing a spinal tap, low blood sugar, electrolytes, congenital hypothyroidism, cerebral palsy. I mean, NAS can mimic some of those things. So you're going to be doing your broad spectrum workup and empiric antibiotics. If you're the PEDS person in that setting, and also consulting with a higher level of care if you're rural. And then you should also have Narcan available, in all inpatient and delivery settings. But don't Narcan people because if somebody's opioid tolerant in labor and delivery, they come in on their opioid treatment, whether or their illicit opioids, and then we Narcan mom, then we can be Narcanning baby, and then that can cause a seizure. So do not Narcan people during delivery if at all possible. Hopefully, someone doesn't come in both crowning and overdosing. I suppose that's possible. Try to get baby out and then provide supportive care would be the guidance here. And again, that's hopefully going to be a very rare phenomenon, but it is possible. So then supportive care, not all babies will need this. And again, this is not something I've personally done. I looked at these guidelines, but just so we can be aware of it. Similar to other substance situations, supportive environment, avoiding excess stimulation, try not to make an irritable kid more irritable with environmental stimuli. Skin to skin contact and breastfeeding also are helpful too and should be specifically promoted. There's data for that. Frequent feedings and keeping the infant hydrated. They may need IV fluids. Again, if you don't do this in your rural area, you're going to be talking about transfer to where that can happen. If you're doing part of pre-pregnancy care, you can be saying, hey, you may need to go to Kearney or Grand Island or Omaha or Lincoln for your delivery. Just kind of setting that, or if you deliver here, in Broken Bow or Shadron or what have you, we're probably gonna have to ship your baby. Just be aware of that. But so that everything goes well. And then just explaining what's going on and why also will lower everybody's stress levels, of course. So. Then again, breastfeeding should be encouraged, including while mom continues on opioid treatment. Monitor weight gain. We're going to do that anyway. And then again, breastfeeding has specific benefits, including less severe NAS and less need to give morphine or other drugs to baby. So again, good evidence, do that if at all possible. And then Here's a little bit. This is going to be more for pediatricians and NICU specialists, but I thought it was worth touching on here. Here's a modified Finnegan scale, which is looking at, are they crying? What's their muscle tone? Are they having seizures, loose stools, tachypnea, poor feeding, and just totals it. And there's this algorithm that is from this North Carolina guidance here, and you can either use morphine or phenobarbital. Again, we probably won't be doing this, but you can be aware of what your NICU and PEDS folks may be doing to talk to your families and also to pre-delivery to set them up like, hey, there are protocols for this. It's going to be done by the book. And your baby may not need this, but we'll be ready if we do. Uh, then a brief comments. I heard some people, and this used to be the truism, use brand name Subutex or only buprenorphine and no naloxone sublingual during pregnancy. And people may also say like, "Oh, hey, I'm pregnant. I can't have the Narcan. I only need the Subutex." I no, everybody can have buprenorphine naloxone, which is associated with less misuse ability. And here's a study that I first heard about several years ago. This is the standard here in Omaha, and I think nobody needs just pure buprenorphine because that's more misusable. So, and then getting back to pain, like we said, acetaminophen, duh. Avoiding NSAIDs in the third trimester, as most of us will remember, because you can cause premature closure of the ductus arteriosus, which is unhelpful. And here's this comment from a UCSF source. Again, short-term episodic use of opioids appears to be safe. Morphine, fentanyl, or hydromorphone, if needed for severe pain, are probably your best bets. Regional anesthesia like blocks and other, anesthetic techniques are safe and ideally preferable as opposed to loading somebody up on opioids if they're not on them. And again, first trimester, as we talked about with organogenesis, that's where congenital malformations risk is highest. But again, second or third trimester exposure that doesn't affect anatomy can still affect functional and behavioral issues. Like we talked about at the start, there's a lot that goes into that. But again, all things being equal, counsel your patients, work to avoid that, use other things with your anesthesiologist, your anesthetist, depending on what the situation is. So, well, I am seeing some questions pop up in the chat, so stop me when you need to. And again, don't use NSAIDs in the third trimester. Random comment, ketamine is contraindicated for acute pain in pregnancy. I don't know how many folks are using ketamine for pain, but again, there's a citation here if people want to go chase it down. IV lidocaine is safe if needed, and then gabapentin should generally be avoided per this source due to the potential for causing more severe NAS if it's used chronically with opioids. So we use that a lot in non-pregnant people together, but probably to be avoided in pregnancy. Here's the author who wrote this, so I can give them credit. So then I think we're probably at a stopping point. I've got some things on HIV and Hep B and C too because I'm me and I like those things. But Will, should we take a look at the chat here and see what's coming up?
Sure. Yeah, we got a looks like we got a question and a comment. So the first question is there are specific psychiatric diagnoses resulting from OUD in OB and wondering what are some of the more common ones and any difference from other substance use disorders.
Yeah. So, and Dr. Stull, you can jump in here at any time too. There's not, I mean, a lot of time it's going to be the same things of opioid use disorder, and you need to account for the pregnancy, but I'm not aware, apart from maybe something relating to an intrapartum issue, like maybe a trauma associated with like a rough delivery or something. I mean, there's not really different ICD-10 codes or too much of a different approach, I think, in a more clinical setting. I mean, you're going to look at the patient, take into account their history, and if they have an opioid use disorder, you're going to treat that fairly similarly to what you would do if they weren't pregnant, just accounting for baby, and then you're more counseling them about to help them feel comfortable. Like, yes, you can and should take this treatment during pregnancy. It gives you better odds for you and your baby. And so I hope that's answering the question, but there's not really a different set of codes or a hugely different paradigm when somebody's pregnant as opposed to when they're not. Again, you just want to help them be healthy overall, and there's good evidence, even more in pregnancy in particular, that advocating for people to have access to treatment and encouraging them, counseling them to stay on treatment is in their best interest.
If I might add a little bit to what was said. Depression, anxiety, and one of the biggest fears is, am I going to lose my baby, or is my baby going to be taken from me because of my substance use, and who's going to find out? But kind of the most common psychiatric comorbidities fall in three categories: anxiety, depression, and other substance use problems. Um, and then the other thing that I mentioned, that is who's going to find out, and who's seen my drug screens? Am I going to lose my baby?
Looks like we've got another question came in and a comment. I'll read a comment before we get to the question. This one's from Nick Townley. He says, "Great talk. Infants and OUD mothers need to be watched for a minimum of 5 days post-delivery in Omaha. That typically means 5 days in the NICU, but they're moving towards having infants stay in mother's postpartum room unless infant needs medication." Then he goes on to say that eat sleep console is the protocol or care used at Omaha delivery hospitals. And I see Alex and Todd shaking their heads to that one. Question from Diva asking, can you comment on the use of buprenorphine versus Vivitrol for OUD in pregnancy? If you know or have noticed any outcomes or differences, effectiveness, etc. Thank you.
Thank you for that question. So I'll start here, and again, if the other experts want to jump in, I didn't review Vivitrol or naltrexone versus buprenorphine and obstetrics specifically. I could here probably give me like 2 minutes and access to Google, but I think the reason for that is that in most cases I would not recommend Vivitrol or naltrexone or kind of abstinence-based treatment in general for opioids specifically. Naltrexone has more of a role for alcohol use disorder, and if somebody has both, and then you may consider it. But the evidence for agonist treatment, so with buprenorphine or methadone, is much better than for antagonists, pure antagonist treatment with naltrexone or Vivitrol for opioid use disorders generally. And so, and I think that holds true in pregnancy as well. Again, we could look up the head-to-head, but that didn't come up in the guidelines, and I'm kind of feeling a bit silly I didn't think of it. But I think that's partly because you'd have to have a very exceptional circumstance for somebody who to recommend naltrexone outside of pregnancy and also in pregnancy. Why do that when you can access agonist treatment? Now, if you have somebody who's very highly motivated and does not want agonist treatment, and that's the patient's personal choice, then I would be talking to my friendly clinical pharmacist and or my obstetrician colleagues to look at that. But I think just because the outcomes are usually better with agonist treatments in general anyway, and also the guidelines I've reviewed here recommend agonist treatment, and I think antagonist treatment, especially if it's forcing them to withdraw, would be against these guidelines here. Again, if they come in stable on naltrexone, which I will say is rare, I have a hard time getting my people with alcohol to stay on it, and I don't think I have any opioid people who are on naltrexone. Maybe in the carceral system, if you have somebody who is more like, punitive, you might be running into that. But I would advocate for people, and I would counsel a patient. I think your odds are better if you go on buprenorphine as opposed to naltrexone, so I would be pushing them that way. That's me. So, Ed, Todd, what do you all think about that?
So, um, all three are choices, right? Methadone and buprenorphine and naltrexone or Vivitrol during pregnancy and can be used with breastfeeding. Um, the only thing, a couple things that I would add are that there's less data with naltrexone at this point and pregnancy and breastfeeding compared to methadone and buprenorphine, and that if somebody's already stable on naltrexone or Vivitrol, it's probably reasonable to consider. But um, the individuals that are used to using opiates, regardless of what it is, and then try to stabilize them on naltrexone, especially during a pregnancy, is particularly challenging because they're used to the effect of the mu agonist, or the effect of an opiate. So I think in general, most people would say try to stick with either ideally buprenorphine, or if they're stable on methadone, then stick with methadone um, during the pregnancy. But it is a certainly a good point to raise, and most importantly is I think individualizing treatment and looking at what they'll be compliant with, and then going from there. The one advantage of um, the Vivitrol, unless you're using a long-acting form of buprenorphine, is that it is long-acting, meaning it's monthly.
So yeah, Alex said he found an article that he'll send out. I can include that in my post email follow up to this training. I'm not seeing any other questions in the chat right now. Alex, if you want to continue with parts of your presentation, it's up to you.
Yeah. Well, and maybe I should have made this an entire different talk, but I couldn't help myself. So we can go through this real quick. And yeah, thanks for the question. So it looks like naltrexone is a viable option. And, somebody's doing great on it and wants to stay on it. It appears safe and effective. But if somebody is on naltrexone and relapses, it has especially PO, it can have a shorter half-life and it does cross the placenta, and so the stakes are a bit higher of like if they do relapse, which addiction is a chronic relapsing remitting condition, we know this, then relapse could have more significant consequences. But again, I have this article here, and I will send that out. So, oh, thank you. So, Orwell will beat me to it and make me look the fool. So, okay, so again, just they mentioned HIV in the ACOG guidelines there. I wanted people to be briefly aware of some of the things that are out there if you're not an HIV nerd like me. People who can get pregnant because they are using their vagina for sex, which is how we think about this to be inclusive of trans people who have their own unique, very high risks due to social determinants of health for some of these issues here. Should be offered TDF, FTC, or Truvada, tenofovir disoproxil, which is the active drug. Tenofovir alafenamide is a prodrug that's activated in the nucleus, and so you can use much lower doses. Less risk of bone and kidney toxicity, which isn't much with Truvada, but it's a lot less with TAF. And again, if you have somebody who can get pregnant, a cis woman, a trans man, because trans men can get pregnant, or a non-binary person with a uterus, you should be, and they're interested, and you have the chance to talk to them. We should be offering them. We should also be doing universal screening for sexual health, which again helps normalize this and reduce stigma and not just say like, oh, you look a little queer, we better talk to you, or like, oh, you look straight. I'm sure you don't need this. It's like that's stigmatizing. Try to talk to everybody. Um, so uh, there is a long-acting injectable named Apretude or cabotegravir that you might hear about. We have people ask about this here in Omaha to an extent. I don't know if there's as much knowledge rurally, although social media is a thing. People talk. Using cabotegravir, which is an every 2 month injection for prevention, has some unique advantages, but it's also the stakes are high. Like if somebody ghosts you, it stays in their system for years at a subtherapeutic level, and so you can get resistance to the cabotegravir, which is an integrase inhibitor, which is the current backbone of or the active treatment for most people living with HIV. So if you get resistance to that class, they're not out of options, but that's bad, and it makes things a lot more complicated. And you can also get this smoldering presentation of HIV where you have low viral loads. It's very tricky, and it gives the HIV experts some heartburn. So if you're not like I personally, even though I have studied a lot about HIV and I'm going for my certification later this year, I wouldn't do cabotegravir for PrEP. I wouldn't recommend that for probably anybody on the call here. Truvada and Descovy, very safe. I recommend that for everybody in primary care or in addiction treatment if somebody needs it. But again, just if you care about it, that's my take. So, okay. There we go. And then just briefly, as we may remember, people with HIV typically have two nukes and a non-nuke of some kind. That's typically an integrase inhibitor. And bictegravir, or brand name Biktarvy, is the current preferred treatment for most people living with HIV. Concerns about that with pregnancy. There was some initial concern about neural tube defects based on some data from Africa, where a lot of this data comes from, because social determinants of health are real. But the rates now appear comparable to background rates, because some people who don't take any medicines during pregnancy will have neural tube defects. So if you have somebody who's living with HIV, probably their HIV provider should know this, but they can and should stay on this before, during, and after pregnancy. Obviously, controlling HIV is best for mom and baby. And then here's a link to the HIV guidelines, which are quite Googleable. And for most of you, you won't be running this, but you may be aware of it as you're working with people. There is a higher rate of HIV in people who've injected drugs and or had riskier sex behaviors, whether voluntary or involuntary, which goes along with substance use disorders, as we know. Uh, then also, like I mentioned, the injectable PrEP, there's also injectable treatment. Some of my patients have switched to this and they just love it. They don't have to take a pill every day. There's not a bottle that says, hey, look at me, I have HIV, sitting in their house. Many people are comfortable being open about their status. Some are not. Uh, People have told me they feel free, and it's like I don't have the disease anymore. I mean, they do, but like it just can have a profound psychological benefit. So, for pregnancy, there's not enough data for this injectable treatment. It's an NRTI, or an NNRTI, and an integrase inhibitor together, cabotegravir and rilpivirine. So for people who are capable of pregnancy, they're probably not going to be on this. Again, it's just something I want people to hear about because it's out there. And maybe eventually there will be enough data and we can consider this, but for now, bictegravir or Biktarvy is going to be your preferred treatment, or for the vast majority of people capable of pregnancy, who you may be seeing. Then another thing just to be aware of, lenacapavir is an every 6-month injection. It's a capsid inhibitor, which is a whole new novel class. And it worked incredibly well for PrEP in some studies in Africa, where most of this happens, because again, that's how the world works. So stay tuned. This may allow us to take a big step towards ending the HIV pandemic. And I'm not exaggerating. Like, it's that freaking good. Not a lot of data on pregnancy that I'm aware of yet, but again, just some really exciting stuff on the HIV front, which has some knock-on benefits for people living with HIV or who are at risk of HIV, which is a lot of the people that we're taking care of with substance use disorders. So then for Hep B, vaccinates. This is mostly immigrants, people who grew up here in the US, have had access to vaccines. Maybe they've chosen not to. But again, Hep B is entirely preventable. Hep B treatment, I don't think any of us are likely to be doing that. That's nuanced. But tenofovir, which is also used in HIV treatment, is safe and effective in pregnancy and is what most people will be on. Then remember, Hep B immune globulin for the baby at delivery, kind of standard stuff. Hep C, there's no vaccine yet. That'd be cool. But we should universally screen for that for people who are in our care for opioid use disorders and offer treatment. Safe syringe programs reduce these rates. And I think this is, not partisan. There was a bill to get a syringe program. As some of you may know, the NMA did support this, and this is an NMA program. It may come back this year, from what I hear. And so if you want less hepatitis C in Nebraska, please call your state senator and maybe message the governor and say, hey, could we make this happen? And then there's also treatment as prevention. You can't transmit Hep C if we already nuked it. Since 2020, everybody who's pregnant should be screened for Hep C each pregnancy. This will help us make sure we're not missing people. You can use Hep C treatment in pregnancy, but most of the time, since that's a chronic long-term thing, especially if it's close to delivery, the ask will be from the obstetric people to hold off on that. But it certainly can be done. And if you're having people with Hep C, another thing besides this I'm doing is talking to the Hepatitis Elimination Coalition with Nebraska DHHS. Contact them or get a hold of me if you have someone with Hep C, pregnant or not, and you're not sure how to go about with that. I'd love to help because I think it'd be fun to destroy all the Hep C in our entire great state of Nebraska. And there's some pangenotypic treatments that the treatment has gotten easier and better. there are still some roadblocks of like prior auth and like, are you a certain type of subspecialist? You know, okay, we're not going to let you treat them. Those are bad and not patient centered. There's some NMA efforts to hopefully make that go away too, which will be awesome so that we can all cure people when we find it. So, okay, and that is the end of my ranting about stuff for a lot, and I hope you all liked it. And this was from a NASA astronomy picture of the day from a little bit ago, and I just like space, so there you are. Let me make sure there's not any other questions. Okay, and I see Will's survey. Please, everybody go there. Make sure you fill it out and rank my definitely take dock a point for my meme failure with that Street Fighter video. I practiced it and it worked when I practiced, but that definitely detracted from the comedic effect here. Will, any other things you're seeing in the chat there? Well, and I
I'm
guess
not.
just thank you so much. Like again, this is why I joined because I had a former resident in this situation who hadn't gotten as much training as I would have wanted and who was like, I want to help this person. I don't know what to do. So I am thrilled to be part of the solution instead of part of the problem with helping this be more accessible across our entire great state of Nebraska.
Awesome. Thank you, Alex. I'm not seeing any other questions. So yeah, like he said, my link is there in the chat. I'll also send out an email that will include these great slides from today. A lot of good information. Maybe you can try the link in those slides and see if the meme works that way. Um, Otherwise, I think we can call it a training, call it a day for the training, and hopefully see everyone back in a couple of weeks. Ed's giving a talk on the neurobiology of addiction. So have a great day and hope to see you. So hope to see you. And like Alex said, please reach out to us, contact me, and I can connect you with him if you have any questions or need some consultation on these issues. That kind of time is covered by our grant. So don't hesitate to reach out. Thank you.